This presentation will review documentation, the electronic health record, and reporting. Healthcare documentation is any written or electronically generated information about a patient that describes the patient's health, the care and services provided, and the dates that this care was provided. These records may be paper or electronic documents such as electronic medical records, faxes, emails, audio tapes, videotapes, and images. The primary purpose of healthcare documentation and record-keeping systems is facilitation of information flow that supports the continuity, quality, and safety of care. The goal in documenting care is to describe the facts clearly and concisely to improve intra- and interdisciplinary communication. Standards for documentation are established by each healthcare organization's policies and procedures. They should be in agreement with the Joint Commission's standards and elements of performance, including having a medical record for each patient that is accessed by only authorized personnel. General principles of medical record documentation from the Centers for Medicare and Medicaid Services include the need for completeness, legibility, the reason for each patient encounter, including assessments and diagnosis, and the plan of care, the patient's prognosis, and any changes in diagnosis and treatment. The American Nurses Association has identified principles of nursing documentation related to the characteristics of documentation, education, training, policies and procedures, protection systems, entries, and standardized terminologies. The ANA's model for high-quality nursing documentation reflects the nursing process and includes accessibility, accuracy, relevance, auditability, thoughtfulness, timeliness, and retrievability. Accurate documentation is necessary for hospitals to be reimbursed according to the Diagnostic-Related Groups, or DRGs. DRGs are a system used to classify hospital admissions. Each DRG is reimbursed at a specific rate, and the payment is often based on documentation supporting the hospital stay. The medical record serves as a major communication tool between staff members and as a single data access point for everyone involved in the patient's care. It is a legal document that must meet guidelines for completeness, accuracy, timeliness, accessibility, and authenticity. The medical record promotes continuity of care and ensures that patients receive appropriate health care services. The record can be used to assess quality of care measures, determine the medical necessity of health care services, support reimbursement claims, protect health care providers, patients, and others in legal matters. It is a clinical data archive. The medical record serves as a tool for biomedical research and provider education, collection of statistical data for government and other agencies, maintenance of compliance with external regulatory bodies, and establishment of policies and regulations for standards of care. Please review the importance and application of each of the following statements as it relates to the medical record. Paper-based medical records have served clinical practice for many years. The formal structure of these documents has changed significantly over time, moving from very unstructured to structured to chronological to only task-oriented structure. There are many problems that can result from paper charts. It can be difficult to locate a particular chart because it's being used by someone else. It can be in a different department, or it can be misfiled. The paper chart is only available to one person at a time. Entries into a paper medical record are traditionally made with black ink only to enable copying, scanning, unless the facility requires a different color of ink. The date, time, and signature with credentials of the person writing the entry are included in each entry. No blank spaces are left between entries because they could allow someone to add a note out of sequence. The electronic medical record, or EMR, is a record of one episode of care, such as an inpatient stay or an outpatient appointment. The electronic health record, or EHR, is a longitudinal record of health that includes the information from inpatient and outpatient episodes of healthcare from one or more care settings. In the American Recovery and Reinvestment Act of 2009, the government mandates that the use of certified EHR for each person in the United States by the year 2014. Although the EHR varies among healthcare facilities, the major components are health information, diagnostic test results, an order entry system, and decision support. Health information comprises patient data such as demographics, assessment findings, flow sheets that include point-of-care results, diagnoses, nursing treatments, and a medication profile listing historical and currently active medication orders. The nursing process is integrated into the EHR through documentation related to each of the 5 steps: assessment, diagnosis, planning, implementation, and evaluation. Diagnostic findings include current and historical results from procedures, lab tests, and X-rays. There are many benefits to the electronic health record system. Computerized provider order entry allows clinicians to enter orders in a computer that are sent directly to an appropriate department. Decision support in electronic records may include medication interaction screening and reminders for preventative health actions such as vaccinations. More sophisticated decision support systems assist in the diagnostic process and include recommendations for treatment. The electronic record enhances communication between all members of the healthcare team who can access and update the record simultaneously. Adoption of the EHR system produces major cost savings through gains in productivity and error reduction, which ultimately improves patient health status. The most common benefits of an electronic record are increased delivery of guideline-based care, better monitoring, and reduced medication errors. Use of EHRs can reduce storage space, allow simultaneous access by multiple users, facilitate easy duplication for sharing or backup, and increase portability in environments using wireless systems or handheld devices. Although data are often entered by keyboard, they can also be entered by means of dictated voice recordings, by light pens, or handwriting and pattern recognition systems. Computer programs can convert these types of data into text. The EHR supports administrative processes with more efficiency and time data abstraction for scheduling, billing, and claims management. Physicians, nurse practitioners, nurses, medical assistants, physician assistants, unlicensed personnel, social workers, and therapists may contribute to the EHR. Check the facility policy for documentation guidelines. Laboratory data and other test results are available in inpatient and outpatient settings so that care decisions can be made. In some circumstances, such care as taking vital signs, assisting with activities of daily living, and documenting their outcomes can be delegated to a UAP or unlicensed personnel. As more healthcare facilities implement EHRs and EMRs, the quality of nursing documentation improves, enhancing patient safety and communication with other providers. However, implementation of electronic records does involve a learning curve as staff become accustomed to the new system. Consideration must be given to how the new system fits into the existing workflow. The nurse must have a basic level of computer competency in addition to understanding documentation principles. Disadvantages of use of computers for documentation include computer and software failures and problems if there is a power outage. Therefore, any facility with an EHR system must have a computer support system, maintenance available at all times, and have a backup plan in the event of a power outage. Access to the EHR is controlled through assignment of individual passwords and verification codes that identify people who have a right to enter the record. Passwords should never be shared with anyone. Healthcare information systems have the ability to track who uses the system and which records have been accessed. These organized tools contribute to the protection of personal health information. The move to electronic documentation requires that computers be readily available to healthcare staff. Originally, computers were located in the nurses' stations for use by all. Many facilities now support point-of-care documentation with computers in each of the patient's rooms and mobile devices such as computer tablets or workstations on wheels that can be rolled to a patient's bedside. The ability to document at the point of care supports the goals of timeliness and accuracy of documentation. When reviewing the patient's information, ensure that the computer screens are not visible to others in the area. Always log off when finished documenting in an EHR. The delivery of safe, evidence-based, quality nursing practice requires nursing documentation be clear, accurate, and accessible. Nursing documentation is an important part of effective communication among nurses and other healthcare providers, and is part of the permanent medical record. The documentation records the care that each nurse has provided, contributing to the patient's outcomes. Events should be reported in the order that they happen, and documentation should occur as soon as possible after assessment, interventions, condition changes, or evaluation. Each entry should include the date, time, and signature with credentials of the person documenting. Double documentation of data should be avoided because of legal issues that can arise due to conflicting data. The documentation format should be used to reflect the care that patients needed in the practice setting. Interaction with physicians and other healthcare providers are also included. Documentation should be clear, concise, complete, objective, factual, non-judgmental, should have proper spelling and grammar, should be recorded as soon as possible in the order the events occurred. Nursing documentation is guided by the 5 steps of the nursing process. Expected nursing documentation includes nursing assessment, the care plan, interventions, the patient's outcomes or responses to care, and the assessment of the patient's ability to manage after discharge. Care plans provide treatment guidelines for individual patients and are part of the permanent health record. The care plan should clearly identify patient preferences with goals that have been mutually developed by the patient and the nurse. In addition, you need to make sure that you only use standardized language when you're charting and accepted abbreviations that have been approved by your facility. In addition, the Joint Commission develops a do not use abbreviation list each year. If you slideshow and view show this slide, you can click on this link and an updated document will appear. Nurses must be aware of the danger of using abbreviations that could be misunderstood or compromise patient safety. This is why the Joint Commission has comprised this list of do not use abbreviation and updates this list on a yearly basis. It is also important that the nurse only uses accepted abbreviations or acronyms that their facility uses for effective communication among providers. Nurses use a variety of documentation formats, usually based on facility policy. Source-oriented charting gives each profession a separate section of the chart to record their narrative charting. The nursing notes may be a narrative format or problem-oriented format. Narrative charting is chronologic, but it does have some drawbacks. Narrative charting format can be time-consuming and contain lengthy notes that may not add to the care progress. Problem-oriented documentation can be completed in a variety of formats and follows a selected structure. This slide documents several different types of problem-oriented documentation. Charting by exception reduces charting time by assuming certain norms. For this type of charting, each facility must define what is normal. Any assessment finding outside of normal is charted as an exception. Flow sheets and checklists may be used to document routine care and other observations that are recorded on a regular basis, such as vital signs, medications, and intake and output measurements. Data collected on flow sheets may be converted to a graph which pictorially reflects patient data. Flow sheets and checklists are part of a permanent medical record. A medication administration record, or MAR, is a list of ordered medications along with dosages and times of administration, on which the nurse initials medications given or not given. A paper MAR usually includes a signature section in which the nurse is identified by linking initials used with her full signature. The EHR includes Electronic Medication Administration Record, or EMAR, Many facilities using electronic records have incorporated barcode medication administration, or BCMA, into the process of medication administration. Using a portable scanner, the nurse scans the patient's wristband and the medication to be given. If the EMAR and the scanned medication do not agree, the nurse receives an alert about the potential problem. The use of the BCMA or the EMAR allows the nurse to obtain a report of medications given, or held, or due. Originally, the Cardex was a non-permanent filing system for nursing records, orders, and patient information that was held centrally on the unit. The Cardex contained patient orders and demographic information. Although computerization of records may mean that the Cardex system is no longer active, the term Cardex continues to be used generically for certain patient information that's held at the nurse's station. An admission summary includes the patient's history, a medication reconciliation, and an initial assessment that addresses the patient's problems, including identification of needs pertinent to discharge planning and formulation of a plan of care that's based on those needs. The discharge summary addresses the patient's hospitalization course and plans for follow-up and documents the patient's status at discharge. It includes information on medication and treatment, discharge placement, patient education, and follow-up appointments and referrals. Nursing notes are legal documents. The medical record is seen as the most reliable source of information in any legal action related to care. When legal counsel is sought because of negative outcomes of care, the first action taken by an attorney is to acquire a copy of the medical record. Documentation mistakes must be acknowledged. If an error is made on paper documentation, one line is drawn through the error with the word error placed above or after the entry, along with the nurse's initials, followed by the corrected entry. If an error is made in electronic documentation, it can be corrected in the screen view, but the error and the correction process remains a permanent part of the electronic medical record. Log-on access to electronic records identifies the person making the change. Any correction in documentation that is indicated as significant change in patient status should include notification of the primary care provider. Timeliness of documentation depends on the patient's condition. When the patient's acuity or complexity of care are high, documentation occurs more frequently. Waiting until the end of the shift to chart creates potential for documentation errors that may result in missing information regarding nursing assessments and patient outcomes. The principles of documentation remain the same regardless of whether it's completed on paper or in an EHR. However, electronic recording, transmitting, and receiving of patient information poses significant challenges for nurses in regarding to confidentiality and security of patient information. The confidentiality of patient information must be safeguarded and the information shared only with individuals who have a need or right to know. In healthcare, confidentiality addresses the ethical principle that assumes a healthcare professional will hold secure all information related to the patient unless the patient gives consent for disclosure. In the context of recorded information, the right of privacy refers to the expectation of controlling or, in some cases, the legal right of a person to control access to personal information. HIPAA, originally passed in 1996, creates standards for protection of personal health information, whether conveyed orally or recorded or in any other form or medium. The Act clearly mandates that protected health information may be used only for treatment, payment, or healthcare operations. Nurses share the responsibility for preventing breach of this information. HIPAA privacy standards should be applied during phone, email, fax, or internet transmissions of protected health information. Patient information should be shared and the EHR access only in private work areas. EHR access is password protected. Patients' rights include obtaining, viewing, and updating their own copy of their medical records. Methods for implementation vary by facility and type of medical record. The American Recovery and Reinvestment Act of 2009 updated some aspects of HIPAA. It required requested EHR be transmitted to the patient within 30 days at the cost not exceeding the expenses incurred. Handoff report can be given to other providers in several different ways. This can be as a face-to-face meeting, by telephone communication, it can be written or recorded. The information exchange can take place between providers, between shifts, at a time during unit transfer, during discharge, or during referral. Transitioning patients from one type of care to another, acute care to long-term care, or inpatient to outpatient care, involves risks resulting from lack of uniformity in the handoff process and inadequate training on how to communicate during the transfer of care. Staff may not fully realize the importance of the specific patient information needed in the care transition process. When complete and accurate information is not shared during the handoff report, patients may not get the care that is needed, proper medications, or recommended therapies. Handoff provides accurate and timely information about patient care, treatment, services rendered to the patient, addressing the patient's current condition, and any anticipated changes. Information in the handoff includes the transfer of authority of responsibility for the patient's care. Patient information that supports care delivery and clinical decision-making must be shared to facilitate the continuity of care. The handoff process can be an opportunity for collaborative problem-solving. Improvement in the handoff process can increase the patient's safety and promote positive patient outcomes. During an average hospital stay, approximately 4 days in length, as many as 24 handoffs can occur for just one patient because of changes in shifts every 8 to 12 hours and many individuals that are responsible for care. An ineffective handoff can lead to wrong treatments, wrong medications, other life-threatening events, increasing the length of stay and causing patient injury and possibly death. Unfortunately, wide variations exist in the quality and quantity of information shared in shift report. The Joint Commission data analysis indicates that communication problems were the primary cause of 65% of Sentinel events between 1995 and 2004. In 2005, 70% of Sentinel events were caused by communication breakdowns, and 50% of these occurred during patient handoffs. To improve the effectiveness of communication among caregivers, the Joint Commission introduced the National Patient Safety Goals in 2006, which became standard in 2009, requiring implementation of a standardized approach to handoff communications. Implementing a standardized process for handoffs is the best way to avoid errors. In many sites, the move to standardized shift reports consists of bedside reports that include incoming staff, outgoing staff, and the patient. Successfully implementing bedside reporting is seen as providing a real-time exchange of information that increases patient safety, improves quality of care, increases accountability, and strengthens teamwork. Interdisciplinary patient care conferences and rounds are a major source of communication between healthcare professionals and patients. Current handoff mechanisms vary from hospital to hospital and even from unit to unit. A communication format specifically suggested for nurse-physician interaction is SBAR, a situation briefing tool used by the U.S. Navy. The SBAR model, not unlike the nursing process, begins with the active situation, the related background, the assessment of a problem, and recommendations for a solution. SBAR is used to report to healthcare providers situations that require immediate action. To define the elements of handoff of a patient from one caregiver to another, such as during transfers to another unit or during shift report, and also during quality improvement reports. SBAR is often used by nursing as a handoff tool and is a structured method for all communications between providers. SBAR offers a simple way to help standardize communications and allow parties to have common expectations related to what is to be communicated and how the communication is structured. When documentation is completed electronically at the point of care, the potential for errors and omitted information is decreased. A handoff report can be printed that is specifically designed to address all pertinent information for a patient assignment. One study found that using electronic systems in the process ensured more effective and efficient shift report centered on patients' needs. Even with computerized systems, nurses should continue to ask questions and seek additional information for handoff reports. Patient safety issues are heightened when information is transferred during intra-hospital transports. Teamwork and collaboration are demonstrated when nurses appreciate the risks associated with handoffs among providers and across transitions of care and follow communication practices that minimize those risks. The use of verbal orders or telephone orders has been limited now to only emergency situations. The primary care provider can access the EMR from a smartphone anywhere, or a handheld device, or a personal computer, and enter and send orders directly to the appropriate department. This removes the nurse or the unit secretary from the ordering process and decreases the possibility of error. An incident report may be an occurrence of a fall, a medication error, or an equipment malfunction. Incident reports are objective, non-judgmental, factual reports of an occurrence and its consequences. The incident report is not part of the medical record, but is considered a risk management or quality improvement document. The fact that an incident report was completed is not recorded in the patient's medical record. However, the details of a patient incident are documented. Incident reports which are used in risk management process must include only facts and not opinions.